much for the invitation. My topic is about imaging for tricuspid interventions. Is 4DIs ready for prime time? We gain more and more evidence about the possibility of reducing tricuspid valve regurgitation using our interventions. But we know that imaging can be tricky. And if we have a good and optimal imaging quality, then I'm afraid that the answer to the question if 3DIs can replace TOE is negative. But the optimal quality of the imaging is not always the case. And we have cases with horizontal heart, with shadowing due to left-sided prosthesis and pacemaker leads or interatrial septum. And we know that tricuspid valve leaflets are much more thinner than the mitral leaflets. They have a greater anatomic variability. Tricuspid valve is far away from the esophagus, and we cannot really gain an fast view of the tricuspid valve. And talking about imaging modalities in the tricuspid valve interventions, so far, nowadays, vast majority of the interventions are done with fluoroscopy and 3D TEE, and only in cases of suboptimal imaging quality in some patients, then alternative imaging modalities come to the game like 3D TTE and the new player in the game, the 4DIs. And that's how eyes evolves in the years, starting in 2000 with 2DIs, the first introduction of eyes, and then 2007, the 3DIs, until a couple years ago with the introduction of the modern 4DIs systems. And we can use eyes to close an ASD or a PFO or a LAA or even a PVL, perform a TAVI or repair in the tricuspid or mitral valve. And we know that eyes improves safety, provides greater confidence in procedural success, and increases access to interventions in patients with contraindications to TOE. And both TE and eyes have strengths and limitations, but we know that eyes can contribute to avoid intubations, to reduce the cost, reduce the procedural time, and enable faster or even same-day discharge. We have 3 eyes platforms, 3D eyes platforms commercially available: Siemens with IQNAV Volume, Biosense Webster, New Vision, and Philips with VeriSight Pro. Each one has pro and contras, but in any cases we see we can gain very nice images with the 4D eyes catheter, our devices, and the tricuspid valve. And the last brand new paper about structural heart imaging using 3D eyes in JACC describes the way to reach the tricuspid valve. We have to go through the inferior vena cava, reach the right atrium, flex our eyes catheter towards the tricuspid valve, and then use the biplane modality and the real-time MPR, and of course combine it to the TOE, who preferable should be put in the stomach and have the transgastric views. And another field to use the 4D eyes is the annuloplasty of the tricuspid valve with cardioband. It increases the safety and reduces the time of the intervention. With 4D eyes, we can have fantastic images, 3D images from the atrial and the ventricular side. And another point to discuss is how is the ideal workflow with eyes. The imager should stay on the top of the patient near his echo machine after parking the eyes catheter he can manipulate the catheter digitally. Alternatively, he can stay on the table next to the implanter so that he can optimize the probe, but he needs a second person for the TOE imaging. There are a lot of challenges for the 3D eyes. The main of them are the cost of the catheters and the software, the inferior imaging quality, the movement of the eyes probe through the procedure, and the greater learning curve. The interventionalists have to learn the standardized projections of eyes, the new protocols of eyes, the 3D advanced imaging principles and interpretation, and of course he has to build an improved relation to the echo guy. But eyes can provide more consistent imaging because it is not dependent on esophageal position. Tricuspid valve anatomy can be more variable, and 3D eyes is an excellent alternative echo technique to TOE, and 4D eyes allows for the ability to park and image. We need more evidence required for establishing safety, feasibility, and impact on patient outcomes. We need standardized clinical imaging protocols. We need guidance on training requirements and prospective data. In summary, there are 3D eyes options commercially available. There are remain a lot of unanswered questions. How is the ideal workflow? Which is the role of the imaging specialist? What's happening with the reimbursement of the 4D eyes catheter? In which procedures would benefit most from the use of the eyes catheter? And if it's adjunctive to TEE or it came to replace the TEE. Thank you very much.
Well, great idea to have additional imaging, at least that's how we use it at this point. And perhaps in the future with greater resolutions we get replace the TE, but now use as adjunctive to TE for the tough cases. Let's move on to the live in box so we can see practically how